Good morning. My name is Rose Kakoza, and I'm going to take you back to when I was just starting out as a new primary care physician in the Phyllis Gen Center and got an email from a wonderful colleague about her patient, Susie. So the subject of the email was favor. And for those of you who practice clinical medicine, you know that that is often followed by a very complicated patient presentation. And this email was no different. She described Susie as a 55-year-old woman with diabetes, hypertension, chronic kidney disease, multiple sclerosis with chronic pain, who was wheelchair-bound, and then went on for several paragraphs to describe how challenging Susie had been to manage over the past several years. She talked about how out of control her chronic medical conditions were, how she was non-compliant with her medications, how she frequently didn't come to her appointments and was very hard to engage in her care. The quote that stuck out to me the most, though, was when she said, even when Susie comes to her appointments, she's often miserable and overwhelming. I think she'd be perfect for you. And you know, Susie was perfect for me. She represented the kind of patient that I went into primary care to take care of. It didn't make the email any less overwhelming, but nevertheless, I took her on and pored over her records and came up with what I thought to be a very comprehensive care plan. So when Susie came in to see me for her first visit, I felt I was ready. I went over the risks of poorly controlled diabetes, my plan to titrate her insulin and augment her blood pressure regimen. I was very detailed, and it did not go well. The following 6 months also went poorly. Plan after plan failed. Susie continued to no-show to my appointments, and she actually was even hospitalized for a stroke. I hit a wall with Susie, and then something changed. I did a home visit. When I went to Susie's home, I was able to just sit with her and listen to her story. As I sat in her living room, I was surrounded by 10 members of her immediate and extended family that lived with her in her 2-bedroom apartment. I was able to talk to her daughter, who struggles with bipolar disorder, and shared with me that experience. And I saw how lovingly Susie interacted with her family. And I was sitting there, I realized that things were changing, and most notably, I was changing. My perspective changed. I realized that I had been looking at Susie through a medical lens and really didn't know much about her social context, and that I had to change my approach to meet her needs and perspective. Susie changed too. She started to come to her appointments after that visit. She started to open up and show her sarcastic sense of humor. And I was able to build a team of nurses and social work around her to meet her multiple barriers to care. And over time, we were able to see her slowly begin to improve medically. It was months later that Susie told me that it meant a lot to her that she mattered enough for me to come and listen to her side of the story. And as I reflected on that experience, I thought about how 1/3 of the patients in our practice were just as complex as Susie, and how are we going to meet their needs in a similar way. So I went to the literature and I found this graph, which may be familiar to some of you, as it represents the burning platform for this issue in medicine. Although patients with complex care needs represent about 5% of the patient population, they account for 50% of healthcare costs. And what struck me the most was the fact that complex care teams have really risen to the top as a primary care delivery strategy to meet the needs of this patient population. Often these teams are multidisciplinary with a dedicated nurse care manager. But how are we going to do this in my large academic primary care practice where we have limited staffing and an inability to protect staff time to do this type of work? Well, that was the challenge of my fellowship project. So we pulled together the Gen Center Complex Care Management team composed of LPNs, nurses, social work, pharmacy, and providers. We were able to meet weekly to review our complex care patients. And we spent a lot of time training, finding validated risk assessment tools and looking at different care management models. But we really wanted to make sure, especially given my experience with Susie, that we didn't lose the person behind the complex patient label. So how are we going to change our approach? We decided that instead of meeting the patient with a risk assessment tool up front, we were instead going to focus on getting the patient's story. And we did that using structured interviews to learn more about the patients, who they were, and what mattered to them. We knew we couldn't do home visits for every single patient, so we gave our patients cameras to document what mattered in their lives and share that with the team. And as we've sort of slowly started an outreach to 5 patients, and I wanted to tell you about one of them, Anna. So Anna was one of our first referrals, and her PCP described her as a 68-year-old woman with diabetes, hypertension, chronic back and knee pain who needed a walker to get around. However, when Nicole met her and did her structured interview, she learned that in addition to these medical problems, Anna was also many other things. She was a Roxbury native who was an active member in the Elks Club until her son was diagnosed with multiple sclerosis. She became his primary caregiver until he died 2 years ago. She talked to Nicole about the fact that she was really struggling to rebuild her life and reconnect to the world after her son's passing. When asked about her goals, Anna mentioned to Nicole that she really wanted to join the Elks Club again, but had difficulty because she needed to climb a flight of stairs to get into the building and couldn't navigate that with her walker, which related to her second goal, which was to get rid of her husband, what she called her walker. And her third goal was to improve her blood sugars. And what Anna really wanted was just to start taking care of herself again. She took the pictures with the camera and photographed her living room where she spends much of her day. She also took a picture off of the rooftop porch where she liked to look out onto the street in her neighborhood. She also took a picture of the ride, which she's dependent upon to get to her appointments as she can't drive. It was from this place of shared understanding that Nicole and Anna were able to create a care plan that would move Anna closer to her goal of greater mobility and getting back into the Elks Club. And together they decided to start with a focus on diet and exercise. We're still learning and growing as a team and gaining a lot of information from our patients. But what we know now is what works for complex care patients, what works for any patients, is that you need to first get their patient story, learn what motivates them, and get on board. Thank you.